So David Haslam has spent his career shaping the health service. He's worked for 40 years as a general practitioner and then scaled the heights of the health service to be the president of the Royal College of General Practitioners, the president of the BMA, the chair of NICE, and a number of other really quite incredible roles. He's also written a book 3 years ago, Side Effects, and it really has had great acclaim from Waterstones and from The Observer and from many others. And it digs into how the NHS is broken and what it takes to fix it with compassion and consideration and great sense. So I'm looking forward to getting into the discussion today. We have had a pre-discussion just a few days ago, and we covered some of the subjects. And for Let's Fix the NHS, the goal really is to dig into what's necessary to address the systemic challenges within the NHS and to really figure out where the solutions are going to come from and to help craft them. But to get started, Sir David, welcome. Is it Sir David or David? What do you prefer?
Please, Sir David, only when I'm booking restaurants. Otherwise, David, please. Thank you. Not that it ever makes any,
Fine, or David, thank you.
never makes any difference in a restaurant. It's worth trying.
I would imagine if you go to the United States, it could be a little different, but there we go. So let's just get into it by talking about the book and what kind of response have you had? It's probably over 3 years now since you sat down to write it, and obviously COVID was going strong at the time. So yeah, just kind of curious as to that experience, just to get us started.
Well, it's been fascinating. It's really good to talk to you, Steve, because this whole issue of trying to fix the NHS is what's brought us together. I was really struck by the fact that the NHS is struggling, and it's been struggling for most of my professional lifetime. I'm a total fan. I believe that the concept of treating people without the need to worry about how you pay for it, offering quality based on need rather than ability to pay, I think that's one of the great activities of humankind. I mean, I know that sounds a bit cheesy, but that's the way I feel about it. The NHS was 364 days old when I was born, so it's been a real core part of my life. But what I've heard, and as you kindly said, Steve, I've had a large number over the last couple of decades of leadership roles, and I've worked at the top of the health service, and I keep listening to the same answers coming up, that we need to do this, that, or the other, but never quite seems to shift anything. So we keep having restructurings, different ways of organising things, and everything carries on very much the same. We have some wonderful care. I owe my life to some wonderful care that I've personally received. We have some unacceptable care. We certainly have levels of waiting that are completely unacceptable for so many conditions. But I think the thing that struck me is that you can't answer the question if you don't quite know what the question is. And it feels like the question is, what do we do about the NHS? And that's not quite enough. You need to know what's wrong with it, what is the problem, and you're only going to be able to answer that if you know what it's trying to do. And that might sound a very simplistic statement. I think if you or I are ill and we see a doctor, we know what we want them to do. We want them to sort us out, to get us back to health. But is that it? Is that just it on a national basis? Are we trying to deliver health? Are we constantly expanding the expectations, the offer? If you've got a constantly expanding offer and a constantly changing offer and a fixed budget and near infinite demand, that's going to end in tears. So you have to start looking at these things.
As we talked about the other day, it's like infinite growth on a finite planet is a mathematic impossibility, and that need and that perception of need does expand significantly. People are clearly living longer. You know, you mentioned when you were born, and if we take the number of people on the planet then and now, it's roughly doubled, and that in itself creates a need.
Well, on a very, yeah, on a simple human level, but part of the reason I call the book Side Effects is because a lot of the problems that we're facing are side effects of previous work, previous good intentions. Sometimes this is down to policies that governments have come up with. A classic one I talked about was the drive by previous governments to improve access to general practice, which was a fantastic idea, but it destroyed continuity. And there's lots of evidence that having a doctor who knows you and who you know is a good thing. But unintentionally, a side effect of trying to get access better destroyed continuity.
Well, I find that fascinated. Sorry, I find that fascinating in multiple contexts because, you know, we talked about my mother's stroke and the fact that she was 4 months initially, and then after a second stroke, another month in hospital, and it just dawned on me that the amount of time spent on handover, it's just crazy, and not just I'm talking between shifts. You virtually never, even in that time, it's very rare you see the same clinician, the same doctor, the same consultant, and you know. And then I thought of that in the context of the general, general practice. It's the same, and in your book you highlight that. But my question is, how do we in this modern data-driven world where there's a lot of information, how do we go back to relationship-based medicine? It's almost like banking. We talked about finance as well, and one of the big criticisms is we've gone into a data-based banking world as opposed to a relationship-driven world. And I think a hybrid is ideal, but how do we systematize that? How do we create that? Is the question.
Yeah, no, that's absolutely right, and the technology is going to give us a lot of help in this. It's inexcusable that people have to repeat their medical history over and over again. You know, with every clinician that they see, it is completely barking mad. And I don't understand why we haven't been able to sort that one out. Again, it's probably because of the side effects of very reasonable anxieties around confidentiality and issues like that, which are really important. But the excellent has been the enemy of the good, and we're nowhere near the good in terms of this yet. But yeah, like in banking, most of the time, most of us are very happy with our apps and very happy with an ATM machine. But now and again, you need advice, you need help, you need a human, and it'd be quite nice if that human knew you. And the thought of that in the banking sector now is laughable. In the medical sector, it'd be great to be able to see the doctor who knows you. And I'm not being cheesy about some, the 1950s style, always there, 24 hours a day doctor. I'm just talking about the ability to sometimes be able to talk to the person who knows you. And some practice, my own general practice is now trying to work. I'm not practicing anymore. I'm a patient there. Is doing all it can to make sure there is continuity, that you see the same doctor if you possibly can. They've recognised the importance of that. But that's all too rare. And I'm glad that, at least in some of the government's pronouncements, they've talked about that being important and bringing back that relationship, because relationships, medicine is a mix of art and science, and the art bit is a human art.
Can we go back to the that initial thought? What is the purpose of healthcare? I mean, to lose its way, we have to figure out what that direction was initially, and it would really help for you to define, for people who may watch this, what is your vision of the purpose of healthcare?
Well, when it was the arrival of the NHS, I think was fundamentally came out of the insurance systems that had been working prior to that, which were ways of trying to guarantee the workforce kept working. And the NHS, to begin with, I think part of the aspiration was that it would deal with all the sickness that was stopping people being able to work, to get UK PLC working again. How many times have we heard that sort of thing? Also, there was the most breathtaking error of judgment, an assumption right at the start that the health service would reduce cost, because as you improved health, demand would fall. And it could not have been more wrong. What the availability of the NHS did was suddenly disclose the extraordinary amount of need and demand that there was there for dentistry, for eye care, for glasses and all the rest of it. All these things suddenly spread out, and costs escalated and escalated pretty well from year one. And none of that is to be critical of people who seek demand. It's just to recognise that it keeps changing. We've seen this particularly in the area of mental health. The definition of what is mental illness, or what is unfortunate and sad emotions, is a difficult one. And I'm not going to even pretend to say where the barriers of that are, but expectations we've seen over generations have changed dramatically, which means demand for services constantly increases. Things that my father's generation put up with, I didn't put up with. My kids won't put up with things I put up with. That's human nature, but it just changes the game, which is why I don't think it's for me, or I don't think it's for any expert to say this is what the NHS should do. But I do think it is for the public to at least recognise there are limits and work out where those limits are. And I think you can do that through things like citizens' assemblies. This would not be an easy piece of work. It'd be politically courageous, as they would say in Yes Minister, but I think it's got to be done. We cannot go on the way we're going.
The idea around Let's Fix the NHS was really to give people a voice, and those people could be the nurses or the healthcare assistants or clinicians at any level, or the GPs or those who are in care homes. The whole system really. In talking to people, I found an awful lot of people felt helpless. And whether it's junior GPs who want to go to Australia, and TikTok and Instagram is full of people venting and saying how frustrated they are, and that's really worrying. It really is. But part of the solutions is making sure those solutions are crafted in the open. They're transparent. They're thoroughly stress tested, and for people to have overall involvement gives them buy-in. And that could be something simple like voting on an idea and listening to that idea, or it could be something significant like fully costing and formulating a proposal that should be fairly and properly evaluated and in the context of the bigger system. Now, generally, those things are happening, in dark rooms, and there's not that much transparency. And I think key to actually fixing this, if it's possible to fix it, it is figuring out where those problems are and listening to the solutions wherever they are. And I'm sure in your many years of service, you'll have found an awful lot of incredible solutions by the people who are at the coalface.
Yes, absolutely. There's wonderful care and wonderful things being delivered all across the NHS, but the trouble is they don't become generalised, they become localised. There's a terrible tendency sort of if not invented here, things tend not to get used in quite the same way. Often also it's just people don't know about them, or people immodestly don't share them because they don't think they're that big a deal. You can have really simple things like district nurses who visit people in their own home, sometimes in some areas to get a dressing, they then have to contact the general practitioner. The general practitioner then has to write a prescription. The prescription has to go to the pharmacy. The pharmacy has to create the prescription. The nurse then has to collect it and take it back to the patient. Now, that is bonkers. It's completely bonkers, but it's norm in so many areas, which could be solved by ensuring the district nurse has sufficient dressings. It might mean things have to come out of a different budget, but isn't that what management is for? It's to try and sort that sort of thing out. Now, that might sound really trivial, but actually multiplied up by the workforce that's the fourth biggest workforce in the world, then you start looking at these things.
All these things add up. So so that brings on a very interesting question of what is leadership in this context, because an awful lot of leadership is leadership out of fear, and it's applying a set of rules, and it's not sticking your head above the parapet and wanting it to be, for fear of it being shot off. And the reality is, risks need to be taken. If there's no risks, whether that's the leader that would sanction that budget diversion or whatever it might be, someone's going to take a risk. And if you avoid risk at all costs, it increases the overall risk. So I guess, how do you get leadership on every level that's fit for modern times? That's really, which includes that flexibility.
Yeah, that's such an easy question to answer in a minute, Steve. I mean, it's. I think a lot of it comes down to tone. It comes down to one of the problems that we've struggled with, and again, this has been the metrics used to measure quality and activity across the health service were brought in for very good reasons to try and ensure that people really did deliver. But over and over again, we've got to the situation of the cliche goes in healthcare, hitting the target and missing the point. So you manage to deliver the numbers that you have to deliver in terms of work done, but somehow nobody's happy in the entire scenario. And we see that sort of thing over and over again. So I think personally, you have to free up local delivery systems. I don't think you can begin to run something the size of the NHS on a national basis. The trouble is if you try and break it up into smaller units that might function more efficiently, then you get newspaper headlines about postcode prescribing or postcode variability. How is it that in Southampton you can have this and in Winchester you can't? That's a scandal. But if you really want to deliver what's needed for a local area, you have to have those differences, and we have to understand that. But politically...
Can I just throw this in? So I hate to talk about Rudy Giuliani, but I remember a number of years ago, he wrote a rather good book on leadership, and I read it, and this was before, his sort of, say again?
I have it on my shelves, and I think what happened to Rudy Giuliani in the Trump years has been a tragedy, because that was a great book.
Unbelievable tragedy. But we take what he did in New York as the mayor, and there was something they used called CompStat, wasn't it? And that's where they took the different borough chiefs and heads of the police force and the fire department, etc. And on a regular basis, they got them to share their best practice ideas. I think it was once a month or something. And they had a system of capturing all their data for their, crimes or fires and response times, things like that. And essentially, they physically got these people together once a month, and they had to defend their drop in statistics or their, or explain their improvements. And something about that idea struck me as being something that could work in an NHS context, because when you have both transparency, whether you got comparable data and you've got competition, and the communication process that system elicits, it could be something that could help people share that best practice more effectively than they're doing right now. And I think we have to look at other parts of the world for systems that have and historic times when the systems that could be relevant and could be valuable. And I agree that yes, it's difficult to run this on a national basis from purely centrally, but at the same time, if you look at some of the bottlenecks of the trust situation right now and the differences, we've got to find a better way, a hybrid way, where best practice and excellence can be shared quickly and effectively.
No, I absolutely agree. And you've reminded me something I've completely forgotten, which is nearly 40 years ago. I was involved in running a series of evening meetings for general practices in the area of Cambridgeshire where I practiced. And we'd all get together, different practices would get together each time in a different practice. And the host practice was asked to talk about 3 things that they were proud of and 3 things that they found a real problem. And we all used to hear the proud things and say, wow, those are great ideas, and take them away. And the things that were problems, typically one of the group of the visitors would say, why is that a problem? Why don't you try such and such? It worked an absolute dream. And it's a model I need to think about again, because, as I say, it was a long time ago, but it was exactly that sharing of practice. But I think part of the challenge has been I don't want to simply blame politics and politicians, because we get the politicians we deserve, which is a tragic thought some of the time. So we get, at the moment, we've got the Secretary of State talking a great deal of sense about some of his priorities around focusing on primary care, which, as you'll know from my book, I'm a passionate believer in the importance of focusing on primary care, on prevention, on the potential use of tech. And all of those really, really important and got fantastic potential. However, coming out of number 10 is the message that the one thing that really matters is the waiting lists for surgery or for being seen in hospitals. And so the metric on which everything is being now determined is that one, which pretty well guarantees that none of the other 3 are going to at least succeed in the way that we would hope. So we've got this complete mismatch between political, and again, I understand the waiting list thing. I absolutely understand why number 10 would say, we've really got to get waiting lists down. It's the thing that it matters, the population it matters to. But the more we focus on that, the more we stop.
So I guess there's 2 words. There's 2 words in response to what you've just said. Perverse incentives.
Absolutely.
And we have those all over, our economies, and all over our systems, public, private. But obviously these political incentives, they're wanting, people, special advisors will be telling him something simple, something measurable, something that everyone cares about, regardless of whether it's good sense or not, whether it's congruent, whether it's aligned with the 3 shifts, which is what you're referring to. And I agree, it's not, I don't think those 3 shifts are new, but I do think that they're focusing on them is. But
Steve,
is a good strategy for sure.
The tragedy is, not only aren't they not new, they've been said by almost every Secretary of State that I've ever known, but they haven't happened. Right. Because of the perverse incentives elsewhere in the system. That's where the real challenge is. Right. So way back, I mean, prior to the Blair era, so we're talking early 90s, they were talking about a primary care-led NHS, and it never became anything other than a phrase, because it's simply, the focus was always on hospital waiting times.
So we'll come back to those perverse incentives in a minute, but just for a moment, just for a bit of fun, I'm going to make you king for the day, for this session, and I'm going to hand you £5 billion. And I'm going to ask you, how would you allocate that?
£5 billion to do what? Because if I wanted to spend £5 billion on the health of the country, I would probably put it in housing and education and possibly prisons. Now, if you want me to spend it on the health service, or even more on social care. I mean, if I wanted to spend 5 billion, I'd put it on social care. If we want to improve health, we do those first three. If we want to get out of the crisis where we are at the moment, you put it on social care. Why we have this ridiculous boundary between healthcare and social care, other than for fiscal reasons?
Explain that boundary and explain what social care is versus healthcare.
I'm going to struggle because it's not a logical one. If there are some conditions that are deemed to be health problems. You've told me, Steve, about your mother's experience of stroke. Stroke is clearly a health problem which requires NHS input. And the amount of care you receive may be variable, and the amount of availability of nursing care in the home and so on may be very variable and less than one would like, but it exists. But for some other conditions, like, say, Alzheimer's, you're almost, I mean, not quite on your own, but you're much less likely to receive any NHS support. Now, tell me why that makes any sort of sense at all. Social care doesn't just apply to the elderly, and applies to sort of younger people with various lesser abilities of one sort or another. But there is no logical boundary, but there has been boundaries drawn that says these conditions are health, these conditions are social, the NHS will look after you, these, you're on your own, sunshine, you'll have to pay for everything yourself. Now, that doesn't make any form of sense. We then end up in this situation. What is it they say? Around about 30% of acute beds are being in hospitals are held by people who could be discharged home if there was someone to look after them. But if they go home, what's wrong with them doesn't need NHS input, so they don't get anything, so they stay in hospital. Madness, completely the wrong place. And for your 5 billion, thank you very much. That's where I'll put that.
Yeah, unpicking that, it's complex, right? So I have an auntie who she's my sole remaining auntie, and I've had quite a few, and she has Alzheimer's, stroke, dementia, and has done for maybe 12 years. She's in a home. She's been in a home in Bollington probably for the last 6, and she's at the point where and prior to that, a couple of other homes that she was in. So she's been in homes for maybe 10 years. And, she's at the point she doesn't even remember the village that they grew up in, which, or anybody. But she still has got her innate charm. She can tell anyone who comes up to her how she loves the blouse that they're wearing or whatever. But, yeah, and it's complicated, and I've visiting my auntie Nora and others. You see people who I mean, we talk about sometimes taboo subjects not enough, and end of life care is one of those subjects that has to be also talked about. I know it's something you're very passionate about, but what I've seen continually is people are kept alive past the point where it's reasonable for them to have quality of life. I'm not saying it in my auntie's case, but I've seen it multiple times. And where does that fit in terms of, is that care or is that NHS? And that sort of endless antibiotic sort of treadmill and admission treadmill. I mean, these are sensitive subjects, so I don't want to ride roughshod over people's feelings, but
no, they're very sensitive and they're incredibly important. And I'm really clear that any improvements that we can do to end-of-life care, which we absolutely should do, mustn't be for financial reasons. I want to separate that completely out from the challenges for the health system.
Agree.
It's got to be because it's the right caring thing to do for that human. You don't simply, I mean, I do not understand why so often people are rushed into hospital from care homes where people who are almost in the end stage of their life are rushed into hospital for where they die in hospital the care home was their home. The clue's in the word. And sometimes I think that is just down to fear. It's fear of litigation. It's fear of we didn't do everything that we possibly could. It's fear that the relatives will complain. It's fear that someone will complain. And that just feels we've made a misstep there, have taken the humanity out of those last moments of life. Again, good palliative care can be fantastic, really heartwarming. If that doesn't sound a ridiculous thing to see, we're all going to die. So, it's something that we should be talking about. But improving that is to try and avoid some of the over-medicalization of what is a normal step, but doing it for the right reasons, which are human and humane reasons, not because we can't afford to do it in the expensive way.
These subjects are difficult for some people to talk about. For those who are, very sensitive and very emotional, it really is hard. And in a way, part of our education system, in Manchester, there is something they call it Live Well. It's a program to do with health in the community and bringing things like blood pressure assessments and as much that can be brought onto a community basis in order for people to live well. And it includes housing, and it includes, some of the other social determinants, I think the term is. And that seems like it's a good model to follow. But in those community centres or religious establishments or clubs, in a way, we need to create a national health curriculum or a local or adaptable health curriculums. So these discussions can be had and they can be less taboo. And I think, social media and YouTube can help. This potentially can help. But it's one of the things that strikes me that, going through it with my mum and previously my brother, it is something that hits you very suddenly. And all of a sudden you've got to make difficult decisions when you're not really prepared for them. And I think many people are in that same boat. And going back to care for a moment, the complexities around selling asset, paying for, what are people eligible for from their local councils? What are they not? It's a minefield. It's very complex. And it doesn't feel as though it's very personalized. It certainly doesn't feel it's very caring, in my experience.
And it doesn't have to be this way. It's quite simply, we can't go on like we are because, as you've said, pretty well nobody is satisfied with the current situation. Many patients aren't, many carers aren't. I'm not just talking about care of the elderly and so on. We've talked about junior doctors, senior doctors, hospital doctors, GPs, nurses, physiotherapists. Everyone's feeling this isn't right. This isn't how we want it to be. And an awful lot of that, in my mind, is to do with the almost the over-industrialization of health. It's become more a transactional getting stuff done than doing stuff with people. And again, I don't want to be cheesy about this, but the emotional relationship between carer and cared makes a difference to both.
Now, 10-minute appointments or 15-minute appointments, that's a lot to build a relationship, isn't it, within a short period of time? And can we go back in discussing that to that sort of 5 billion allocation? So, to make it's not the end of the day yet. You've still got, some of it to spend. So let's go back to how would you spend it?
If I had to invest it in the NHS, I would very definitely invest it in primary care. And I'm not doing that simply because I worked as a general practitioner. I've worked in lots of sectors in the NHS. I'm looking at international evidence which shows that investing in primary care reduces health inequalities, improves overall health outcomes, improves satisfaction. One of the great mysteries is is that if you were to ask any Secretary of State what you want to achieve, it would be improve outcomes, reduce inequalities. And what do? They put their investment elsewhere in the system, which seems to get more bangs for the bucks quickly. But investing in primary care, in high quality first contact, if that is carried out well, the overuse of the rest of the system can be avoided. Emergency admissions can be avoided. A lot of practices are now developing much more sort of social strategies within their practices as well, where you link population members who are frequently lonely. Population members, I'm talking about humans. The dreadful piece of cliche that was. Talking about human citizens, getting them to just link together in a social way, and
in your book, you talk about this concept of medicine being developed for loneliness, which
yeah.
is like a crazy, a crazy concept.
And I mean, to be honest, the current focus on obesity as being a problem that we have to treat with as many drugs as we possibly can. In the short term, I absolutely get that. Obesity is a massive problem for the health service in every sense, in terms of, heart disease and cancer and arthritis and all the rest. It's a huge diabetes. It's a huge problem. But surely the way to tackle this is around diet and lifestyle. And I'm talking about the food industry more than anything. And yet we're now pouring. The Tony Blair Institute today, as we're recording, has said we should be pretty well sending on demand drugs to obese patients. They don't need to see their doctor. It just, yes, short term, fantastic. Long term, madness.
The irony is, it's like a sticking plaster over an open, festering wound. You got to get to the root cause of it. When you look at outcomes and measurable outcomes, I think you can track, first of all, big pharma and big agriculture. They're two big questions, and we talk about perverse incentives. So, I mean, I know it from the book. You talked about your brother and your father, and they would not have passed so early had some of the medications been around that are around now. And you also mentioned that you're not anti the pharmaceutical industry. I'm not sure where you stand on the food industry, but from my perspective, we're doing an awful lot to destroy our soil and to and to keep people addicted in both with pharma and with food, and we need to have a planet that's sustainable and intelligent. We have to really rethink a great deal of how we live, and I'll rephrase that. I think a lot of that thinking has been done, but it needs to scaled and become mainstream. But if you look at finance that plows into that pharma and finance that plows into those food industries, they push the extremes of behavioral science to sell and market things to people that are not always good for them. And yet they still use these serotonin inducing mechanisms to satiate people's appetites.
I think it's pretty clear that a lot of the activities of the food industry over the last decades have been very similar to the tobacco industry in the 1950s, when the problems of smoking were becoming medically apparent, and yet all the research, as much research as possible, could be buried. I find it deeply, deeply disturbing.
If we go back to the perverse incentives, how do we hold them to account, and how do we give people better choices? When we spoke previously, you talked about how the trend of obesity and all of the issues, it wasn't the same when you were a young boy, and you think something's happened.
Well, people, I mean, classically, whenever you start talking about obesity, there was a letter in the Times a couple of days ago saying, for heaven's sake, all people need to do is exercise more and eat a bit less, and we don't need to worry about all this stuff. Now, I'm always struck by photographs of the Woodstock Festival. That's my generation's first festival. All the photographs of all the people in that, you could see their ribs. Everybody. They were all, today's metrics, we would call them skinny. I do not believe all the subsequent generations have just lost willpower and are just lazy and I don't think there was anything superior about my generation who was skinny at that age. I think the food we were eating was different at that age. And I think if you look at what's happened to just go down any high street and see the average size of the average person, you realize something really quite dramatic has happened. Very taken by Chris Van Telliken's book on ultra high processed food. There's some really interesting work he talks about in that. But whatever the cause is, there's no doubt it's a societal thing, not just individuals being greedy and gluttonous and lazy, which some people would like to say. I cannot accept that. I don't think whole societies change like that. But food industries certainly change like that.
So, I mean, we talked about the economics. We talked about my previous project, or the project that's on hold, Transform Global, and the idea to kind of create a financial institution that can get capital better deployed in a way that can create more jobs, deliver more innovation, create more tax revenue, and gainfully employ many more people than is the case with our concentrated capital system. Major corporations are useful, but they don't actually they strip out more employees than than jobs that they create. Not always. There are some amazing large organizations, but the reality is we need to rebalance our economies, and if we don't do that, the poverty and the inequity and inequalities just keep on increasing. The gaps between those haves and have-nots are huge. And so I guess my question is the links between intelligent economics and healthy economies and a healthy population. How important is that? And to your theory, something's going on. Could that be part of it?
Yeah, I think it's extraordinarily important. And sort of linked to what you're saying, one of the things that always bothers me is the way that, certainly to the Treasury, it looks like the NHS is always a source of demand rather than benefit. The worry is always, how much does this spend? How much does the NHS cost? Rather than what benefit can a healthier workforce, a healthier nation make to our country? So it's always seen in terms of cost rather than benefit, rather than investment. Investing in health and improving the health, I think, addresses so many of the issues that you flagged up there, and this widening inequality can only end in tears.
Right, and that's where I think in terms of the innovation, getting innovation right the way through the country, and we need intelligent models of finance to help fuel that. But we also need it in the in the healthcare system, both internally and external to the NHS. So my view, one of the things we've got to do is really have a sort of root and branch analysis of where we're overpaying for services, where we're not using intelligent energy, where we're, there's so much waste in the system, and often that's because many incumbents are involved. Now, the NHS is for sure free at the point of delivery, although we do have to pay for prescriptions, and we do have to, pay for certain other services, as dentistry and the like. But many of the suppliers into that system are private enterprise, aren't they? And there's a big debate over the privatization of the NHS, and there's an awful lot of strong feeling, quite rightly. And right to the back of this conversation, you said, you are a massive fan, and I am a massive fan. I think the principle of free at the point of services should never be on the table, but innovation should be part of this, and this hybrid system that we've got should be uh, improved. Where do you stand on getting innovation into this complex, massive organization?
I think for me, the fundamental principle should be who pays rather than who does. So I don't mind who does whatever is required, provided the average person doesn't have to pay for it. What worries me is when the only way you can receive certain aspects of care is if you offer to pay. What worries me is seeing general medical practice, the risk of it going the way of general dental practice, where theoretically there's dental availability, but for the vast majority of the population now, the only way you can get timely care is to pay for it. And it'd be an absolute tragedy if that happened for general medical practice. And I think if it happens, it'll happen by accident and by negligence. And no one will claim that it was their policy, but it would worry me. But in terms of the private sector being involved, I don't feel paranoid about that. I worry about, I do worry about things like aspirations to profit levels. I'm completely mystified by things like, the PPE scandal in the COVID pandemic, when I cannot imagine how people thought that was a good time to make themselves rich. It's just not a thought that most of us would have crossed our minds. But yes, we need private enterprise to be able to help us tackle some of these issues, and I have no problem with that at all, as long as at the end of the day it's not the patient who's paying.
Agreed. And I guess, really, competence of procurement is a major issue there,
Yep.
therefore, within the system. And I think one of the challenges, and this often happens in government, politicians are, to some people's view, they're paid a lot, but to others, they're not paid so much in relation to their industrial counterparts. So in the NHS, the people who are responsible for very, very large budgets are paid, a relatively small amount of money compared to the pharmaceutical giants and their executives, or construction, or name any vertical that supplies the NHS, and their senior people and their salespeople are paid an awful lot to essentially sell into that system. And if you look at Donald Trump and, tariffs, and if you look at, the deals that, are being discussed probably behind closed doors, we have to be very careful that we're not, the competence of those doing those deals and making those procurement decisions is up there and able to counter those very high paid executives whose motivation is very often purely financial.
Yeah, no, you make some really interesting points there, and working out what the best solution to that's going to be, and where things like AI may be able to help us in that is a way forward. The solution isn't going to be sort of matching managerial salaries in the NHS with managerial salaries in big pharma. That won't solve this. It's however much they might like it, it wouldn't be the solution.
No, but I do think somehow, getting bonuses based upon savings or based upon, I think getting the incentives right,
Yeah,
I think is really, really important. It's important in government. It's important everywhere.
absolutely. But I've never seen an incentive that didn't drive the wrong behaviour somewhere along the line. So it's those unintended consequences from incentives. When the incentive becomes the thing that drives you, you often lose the point of why the incentive was brought in, and that's as I said right at the start, that's one of the things that happened with the incentives to get people seen by anybody within 48 hours, which was a Blair government target, destroyed continuity, and that was a disaster.
Right. Hence, going back to unintended consequence or side effects, that's really the key is trying to get ahead and understand where those knock-on effects are going to be. And when I say incentives, I don't mean everyone should say
no, just remain clearly focused on the point of what you're trying to do. Why are we doing this? What are we trying to achieve? And that's the critical bit, and that's what I keep coming back to. When you've got that clear in your mind, then it'll make life an awful lot easier.
Very good. And just to wrap up, what do you do for fun outside of this medical world, and what gives you hope?
What gives me hope is my lovely family. My grandchildren are wonderful and give me tremendous hope for the future. What I do for fun, I live in rural Dorset, surrounded by the most idyllic countryside, and I try and walk as much of it as I possibly can.
Amazing. Well, one day maybe I'll take the drive down to Dorset or the train, and we can do this. We can do a Mark II with us getting some exercise. That might be a nice way forward. Well, so David, thank you so much. Or David, I really do appreciate your frank and clear views. I think there's many more questions asked than perhaps we've answered, and what I'm curious to perhaps explore with you another time and with others is how if we were to allocate capital and understanding into primary health care, which I think is my conclusion is that yes, we can better allocate capital in the hospital system. I care very much about thrombectomy and stroke, and we'll be launching a campaign around enabling thrombectomy for 100% of the population. I think the return on investment for government is so high, and it has the potential to save or improve over 50,000 lives in the next decade. And yet we're only 25-30% of the country is covered with the availability for mechanical thrombectomy. So I do think there are occasions where investment into the hospital secondary care system is necessary, but if we are able to redeploy understanding, perhaps using the Manchester's Live Well concept and rolling that out, getting that money, I'd really want to understand how that would be better allocated, where it would go, and where there's opportunities to create enterprise alongside the health system, so economically it can work from the country as well. The more taxes we generate, the more people employed, the better for the system. So there's lots of follow on, but for today, thank you very, very much. I really appreciate it. And just the final words to yourself.
Not at all. It's been an absolute pleasure. Thanks very much, Steve.